All right, now I'd like to welcome to the show my colleague, Jeremy Nighohossian, a senior fellow and economist here at the Competitive Enterprise Institute, focusing on healthcare policy. Welcome to Free the Economy, Jeremy.
Oh, thanks. Glad to be here.
So, as we record this, we are still in the middle of a government shutdown. And one reason why we're shut down, and Republicans and Democrats apparently can't agree on even temporary federal funding legislation, is due to healthcare spending and the expiration of subsidies and health insurance plans. That's all related to the Affordable Care Act, aka Obamacare. Can you just give us a quick run through about why healthcare, these healthcare premiums, why that's so much part of the shutdown politics right now?
Yeah, happy to. I think you have to go all the way back to the writing of the Affordable Care Act. Hmm. And back then, they created subsidies for people who earned up to, but not beyond 400% of the federal poverty level. So four times the income that the government sets for poverty. And beyond that line, there were no subsidies. They call that the cliff, the subsidy cliff. And below that line, there were subsidies, and it was dependent on the subsidies were dependent on how much you earned and what the benchmark premium was for insurance plans in the exchanges. And so for between 2013 and 2020, the subsidies worked just as were written, depending on a percentage of your income. If you were deemed that you could afford healthcare, then you got however much subsidy would fill the gap between what you could afford and what the benchmark premium was. But during COVID, during the pandemic, in 2021, the Congress passed an expansion actually of the subsidies that both increased the subsidies for people who earned less than 400% of the federal poverty level, but also removed the cliff, the subsidy cliff, and for the first time provided subsidies for people making over 400% of the federal poverty level. And these were billed as temporary, and they had an expiration date. And they were meant to, fill bridge the gap during the pandemic, make sure people during COVID had health insurance, had access to health insurance. If people lost their jobs, it kind of accounted for that. And then in 2022, I think, when they passed the Inflation Reduction Act, they extended that expansion of the subsidies for both groups of people up to 2025. And so those expanded subsidies were in place up to 2025. They expire at the end of this year, and neither Republicans nor Democrats have done anything to extend them beyond 2025. And so the Democrats are using that argument to say, look, we're not going to open the government until we do something about extending these subsidies. The premiums are unaffordable. If we don't extend the subsidies, the net premiums, the premiums that people have to pay for, are going to go up because the subsidies will go down, and also premiums on their own are going up. And so the affordability will go down and the premiums that people are paying will go up too. So Democrats are saying we need to do something about this before for us to agree to extending the budget, the total budget for the government.
Right. So when we hear talking points about Americans losing healthcare coverage potentially, or their costs dramatically going up. Uh, this is this is really just a reversion to what the standard policy was a few years ago, right?
Right.
Before this kind of these temporary measures rolled into place, right?
That's right. It is a reversion to the subsidy levels that were passed originally under Obamacare, which like they kind of adapt. They're already pretty flexible because they're set at a percentage of income and
Mm.
according to the benchmark premium. So as the premium goes up and as income goes up or down, those subsidies will adjust. It's like an affordability. It's basically saying we expect people who are making this amount of income to contribute this much to healthcare as a percentage of their income. And so as those things change, that affordability rate stays the same. And then what Congress did in 2021 was saying, we think we're going to lower that affordability threshold. We think people should only contribute a little less, should only have to contribute a little less. And so we're going to have subsidies fill in the gap. And so now in 2025, that affordability threshold is going back to what prevailed in 2020 from 2013 to 2020 under the original ACA, which was never changed.
Right. So when we talk about the households that are eligible for these subsidies, you said it was originally people households making 400% of the federal official poverty level. Like about how much money is that we're talking about? Where like what's the 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 cutoff at which you would have previously not been eligible for subsidies?
So in 2025, for an individual, it's about $60,000 for an individual.
Mm,
For a family of four, it's about what is this? I think 128,000.
mhm.
Yeah,
So we're now having federal healthcare subsidies for people households making well into the low six figures here. So it's definitely not something that just applies to like the very poorest people, like say Medicaid.
that's right. The people who are making between 100 and 400% of the federal poverty level, they will still have the subsidies that were passed originally under Obamacare. And people making below 100%, for most people in the country, they do have access to Medicaid.
Right. So, you recently wrote a blog post at ci.org titled "The Problem with Obamacare is Obamacare." Great title, by the way. Pointing out that the ACA, when it was originally passed, right, was supposed to make health insurance and thus healthcare in general more affordable. And as some analysts used the phrase, they were supposed to bend down the cost curve, right? Because we'd been seeing up that time healthcare costs if you put them on a chart and you looked at the curve that chart created, kept going up and up and up. And the idea was like, well, you need to bend that curve down a little and stop the sort of compounding increase in healthcare costs over time. So have we bent down the cost curve? It seems like we haven't. And then if it's the case that we haven't actually done that, and we've had healthcare costs keep increasing dramatically, can we say that would even the supporters of the Obama administration admit that the ACA had failed by that kind of like basic measure?
Oh, that's a hard question to answer. The first question is, have we bent the healthcare cost curve down? I would say no. And I'd say that is most obvious with the premiums for the exchanges for these what healthcare economists call direct purchase non-group healthcare insurance. Um, I mean, I'd say the ACA had two primary goals. One was to expand coverage to make sure more people were insured, but also, as you said, to bend the cost curve down. And I think even President Obama I think the promise was that premiums for family insurance would go down by $2,500 a year. But in fact, on that, it has failed. For these plans, the costs have gone up, and they've gone up substantially. And I think the premise of the article I wrote, the problem with Obamacare is that yes, the costs have increased, and a lot of the reason is because of Obamacare. And you can even look at this if you go back to some of the debates that were going on when they were writing this legislation, when they said healthcare insurance was unaffordable, that something had needed to be done to bring the costs down. When they were writing this up and deciding who was going to get subsidies, as we talked about, people above 400% of the federal poverty level, they were written out. They weren't eligible for the subsidies. And this was a deliberate decision. And when they were discussing it, they actually did the calculations. And if you took premiums that were prevailing in 2009 and you kind of put them into Obamacare and said these were the benchmark premiums, how much subsidies would people get? Actually, people above the 400% line, they would not get much of a subsidy because premiums at that point were so low that
Right.
they wouldn't qualify, that their income would be high enough that they'd be deemed able to afford insurance with those premiums. So even if they had access to the subsidies, they probably wouldn't receive many because the affordability level was high enough that they'd fall under it and they could afford it without any government support. And now if you look at that compared to now, that's part of the obvious tell that something's gone terribly wrong because now premiums are so high that they can't afford it. Even though the poverty level has increased gradually over time, so the 400% line has increased, but premiums have gone up so much faster that it's for a large segment of people over the 400% federal poverty level, they can't afford the premiums under Obamacare, whereas they probably could have, or they could have almost admittedly by the designers back when it was written.
Well, yeah. So in that, in that time, when we've seen this kind of, perverse set of incentives at play, were were the problems that the ACAs created, were they foreseeable, right? Because there were plenty of Republicans who argued against it being passed in the first place, and they had, a list of arguments about why they didn't think it was a good idea. Were has what has happened since then, was that foreseen at the time, or is it a matter of, as is often the case, I think, with a lot of big government programs, kind of unintended, unpredictable, but still very real consequences?
I think it's a mix. I think a lot of them are foreseeable. For example, I mean, I think even the architects of Obamacare knew that premiums would go up somewhat because they were adding more restrictions, more regulations. They were saying insurance needs to cover all of these new services, and we're going to mandate it covers them, and it has to cover them without any kind of deductible. So it reduced the cost sharing for a lot of enrollees. So that's clearly, I mean, it's that money has to come from somewhere, and
Hmm.
so where's it going to come from? But it's going to have to go through the premiums, and they knew that, and they knew premiums would go up a little bit. Also, the uh, requiring plans to include to enroll people with pre-existing conditions, that was an issue, and of course that would cause costs to go up. And I think for a lot of people that was a trade worth making. So to some extent, they knew the costs were going to go up. I think they didn't envision by how much. And there were certain pieces of this that I think they thought were going to work better than they did. An example of that, an example of the former, where they didn't realize what was going to happen was the medical loss ratio requirement, where they require insurance companies they had to spend 85% of all of their premiums, all their revenues on actual Medicare, thinking that this was going to make sure that costs would stay down, that insurance companies didn't put everything into profits. But I think it's had an adverse effect where now it's eliminated some of the incentive for these insurance companies to reduce costs because if they reduce costs on what they're paying for medical care, then that means they're going to have to reduce everything else, reduce premiums. Like it's going to have this snowball effect on the whole system. So it reduces the incentives for them to actually reduce costs. Second, I think in addition to that, I think they thought some of the regulations were going to work better at controlling costs, like preventive care, and by giving people more access, it would reduce usage of emergency rooms, which are very high cost and urgent care. And I think a lot of those things didn't happen. So what they were hoping would be cost control didn't work, and sometimes it worked in the opposite direction and increased the costs.
Right. And when it comes to government expenditures on healthcare, the the environment created by the ACA and ACA subsidies, as we're talking about, is a big part of the puzzle. Um, but the taxpayer money that federal and state governments spend on Medicaid, those medical services for the poor, is also a major factor. I wonder, do these things interact on a high level, or are they really kind of just parallel silos of government spending?
I think they're mostly parallel. I don't see a lot of evidence to see that they're interacting. So Medicaid is just a completely different system. It's state run. They have negotiate or price controls on Medicaid where they get providers, hospitals, and physicians to accept lower pay rates. And so that sometimes it leads to non-participation by some of these providers. But for the most part, it's a state-run, pretty comprehensive, at least they're trying to make it comprehensive where it includes all the providers um, system that accepts lower rates and covers a lot of people in the low income bracket. And then the ACA is much more private. It's exchanges, it's there's more room for insurers to like create networks that different providers participate in, and so try to lower costs that way. It basically covers two different sets of people. I mean, there are a lot of children and families in Medicaid more so, I think, than the exchanges. Exchanges are probably more catered towards small businesses, people who are self-employed, out of the corporate workforce. So I'd say they're mostly parallel. I mean, there are surely some interactions there, one of which might just be cost shifting, where if Medicaid is paying hospitals lower and hospitals need so much revenue to be able to stay in business, then they might like shift some of the costs from Medicaid to private, but I think the interactions are minimal.
Right. Now, like a lot of major government programs, I feel like the ACA was sold to the public as, at least in part, as the government rescuing Americans from the greedy depredations of private healthcare companies and disciplining the sector, for the benefit of the public. But it seems like major insurance companies and drug companies and hospitals and all these for-profit companies have seem to have accommodated themselves fairly well to the cost and complexity of the Obamacare bureaucracy over time. And so I wonder if is that I mean, was that a sort of legit narrative from the beginning that the government was sort of saving us from these greedy corporations,
That they rein in.
or is it this sort of do they kind of cut a sort of what we might call corporatist kind of deal where we like yes we make certain demands like covering people with pre-existing conditions, but then we also kind of give some sweeteners back in the deal to the companies that have to deal with it.
Yeah, I think the latter is much more the correct narrative for what's happened, that there was a corporatist deal. I don't think you could look at insurance companies or providers, hospitals, and say that they're worse off now than they were 15 or 20 years ago. I mean, yeah, to your point, there are some more regulations, but I mean, mandating included increased participation in the insurance sector and paying for it, adding hundreds of billions of dollars more into the system. I mean, it's worked out to the benefit of both insurers and hospitals. Um, there's been some analysts that have shown that insurance the stock prices for insurance companies have just grown enormously over the past 20 years. They're much more profitable than they were. They found ways to, I mean, it's not just the exchanges, but they are deeply embedded in Medicare and Medicaid, offering what's called managed care plans for both programs, and they've been able to profit from those. And then the providers, so they're getting, I mean, all the money we pay to premiums into insurance companies that eventually ends up in the pockets of providers. So it helps them too. It makes sure that that government is paying some, but everybody's participating in the system and paying into the system. Um, and I think it's there's other regulations too, like 340B. There's just all of these different programs that are meant to help low income people and make sure people have access. But the experienced analysts in a lot of these corporations have found ways to game and to make sure they're getting a good cut of the taxpayer dollar. I think another example here is something that the One Big Beautiful Bill tried to fix, where they were trying to reduce the state-directed payments and the provider taxes that are used in Medicaid that have just exploded over the past 10 years, making Medicaid get bigger and bigger in finances, even though enrollment hasn't gone up that much. And so it's created a lot of incentive for fraud, which has been shown both in the exchanges and in Medicaid. CMS just recently cut a few million fraudulent enrollments of people who were enrolled in two different states where they shouldn't be. So states were collecting twice as much money as they should. So I think all of these are showing that the corporatist narrative is the dominant one.
Well, yeah, and I think we'd also be uh, remiss if we didn't specifically mention one of, I feel like, the top worries and concerns that, a lot of Americans have about their healthcare and their insurance coverage, which is specifically prescription drugs and prescription drug costs and coverage. And, and you recently wrote a study about that, about called iPharmaceutical, that's at CEI.org. Um, what were your findings there, and how does that impact this wider background of, I'll say, ACA financing and all this other stuff?
Yeah, I think pharmaceuticals have helped lower, as far as bending the cost curve down. I think pharmaceuticals have helped reduce costs overall in the healthcare system over the past 20 years. This isn't a point that a lot of people make, but we tend to concentrate on how these headline drugs are really expensive, and they are, that are have just been patented and are new. I mean, the pharmaceutical companies have a monopoly on them, so they charge high prices on these branded drugs. But a lot of times, even despite those high prices, they are actually saving the healthcare system costs overall because they're reducing the need for healthcare services in the hospital sector from physicians. And that's something that has to be taken into account. In iPharmaceutical, I was talking mostly about tariffs and how the tariffs are probably going to raise the cost of these pharmaceuticals, which is going to be detrimental to the healthcare system, but also just into the economy at large. Because, I mean, we're importing generics and brand name drugs from other countries, but we're also producing a lot of these brand name drugs already domestically. And by putting tariffs on these drugs, it's going to shift this cost structure, this supply chain, and increase drugs. And I think so I talked a little bit about how pharmaceuticals are lowering costs for healthcare in general, but another part of the reduced costs is, even though some of these drugs are really high priced now because they're under patent, over time they switch to generics.
Mhm.
And that reduces the cost substantially, like over 50%. And so the drugs that we were using 20 years ago are all generic now. And as important as they were now, they're just or as important as they were then. They're just as important now, but they cost half as much or more, or I mean, or a bigger discount. And so
Right.
that's been reducing the reliance on the formal healthcare sector and improving health overall at a lower cost.
Yeah, I mean, I think that's something that often doesn't get mentioned. The that even a fairly expensive new drug, if it imagine there's a drug that treats a kidney disorder, and it's a new expensive drug, but it keeps patients from having to do dialysis twice a week. That could be a huge net cost savings over time.
Absolutely.
Um, so, I'm thinking also about, what the next steps, what is sort of the big picture next steps in healthcare reform. One uh, one common phrase we hear about is price transparency, so people know what things cost. Um, More kind of like market incentives. Maybe we should have fewer plans that cover everything and more, uh, high deductible, uh, high coverage, catastrophic type plans, and then give people more, health savings accounts, money, or more flexibility in spending, pre-tax set-asides and all that sort of stuff. Um, so in other words, sort of maybe fewer corporatist deals where the government tries to balance every player and give them a little, put a little bit in each pot, and more a kind of consumer-oriented, kind of market-driven system. What do you think are the like opportunities of moving in that direction?
Yeah, I think historically, uh, it's been shown that consumers driving economic decisions are generally what lowers costs and prices. And I think keeping that in mind is probably the way forward. Um, I think putting more of these restrictions and regulations, looking at higher costs and saying, for the government to look at them and then say, oh, we need to fix this by, taxing people more and redistributing that money and then sending it to the insurance companies, that's not going to reduce costs. It will just increase them. And if I think part of the thing we have to do is look at what is it that we want out of our healthcare system? Do we want lower costs or do we want more broad coverage? I don't, those two things might be contradictory. You can't have both at the same time. And I think over the past 10 years, we've been so focused on making sure healthcare covers everything that it's increased costs. And if we want to lower costs, I think actually lowering costs solves both problems because when you lower costs across the board and make it affordable, then people will be able to afford everything they need. And so we're probably concentrating on the wrong thing. As far as specific ways forward, I think looking at some of these, I mean, we have a really complex healthcare system. We have fee for service Medicare, we have private Medicare, we have um, private-ish Medicaid and a different version of private-ish direct purchase, like the exchanges. And they're all designed differently and are working differently. And I think one thing we need to do is look at some of the most successful manifestations of healthcare and try to focus on that. There have been studies showing that the ACA, some of these private healthcare plans are cheaper than Medicaid. So just moving everybody into an exchange might be better for the taxpayer and for consumers than having Medicaid at all. And I think looking at things like that, looking at Medicare Advantage and showing how they're able to bid, how they can cover our seniors at lower cost sometimes, and looking at how that's working and try to build on that and build on some of these private solutions and increase competition and let consumers have more control over what they're purchasing.
Yeah, one interesting thing I've read from some people who have studied costs in healthcare services, that I mean, I maybe would not have imagined, on my own, is that if you look at the sort of kind of frontiers of healthcare, um, these services that are not maybe essential to our like life or continued life, but that are things like LASIK for for vision. If you want to get rid of your glasses, you get the LASIK surgery, or cosmetic dentistry, things like implants and teeth whitening and stuff. They're sort of regulated medical procedures, but they're things that are generally considered kind of voluntary, not essential, so they're almost never covered by any form of insurance. The the cost and quality and accessibility of those services have gotten better over time, right? The real inflation adjusted costs of things like that have gone down. The availability is wider. Um, and the quality and outcomes in many cases is increased more than the what we think of as the essential services, right? And that the reason why those have become more affordable and accessible and higher quality is precisely because they're not covered by insurance, right? Which would be, you would think would be the opposite, right? Because if someone said, oh, you have to cover this stuff, then we would think, oh, well, then it'd be cheaper and more accessible. But it's been the exact opposite. Um, I, you know, I think it's definitely a counterintuitive uh, kind of reality, you know. But I wonder if can we leverage, because it's always tough when you have a big government sort of regulatory economy-wide system. There's no kind of counterfactual, right? There's no alternate universe where we didn't pass the ACA and we could see things turned out better. We have all sorts of arguments about why they might have, but it's hard to see a real world comparison to a federal policy being enacted versus not being enacted. Whereas, and this is one of those kind of unusual instances where I feel like you have an actual real world comparison where there's real data and real cost statistics to look at, that's close enough to mainstream medical procedures where you could say, "Wow, we've got all this other stuff, this LASIK, these dental implants, all these other things, where they're medical procedures where we actually had better cost and accessibility outcomes." What do you think options are there?
Well, yeah, I think insurance is it takes adds a layer of discontinuity, I guess, to the shopping experience. As a consumer, you're one of the things you care about is the quality, but also the price of what you're purchasing. And for insurance, I mean, that's true to an extent, but they're paying for a third party. They care less about quality, for one, and they care less about price. I mean, you might think that they're just as price conscious as consumers, but as I discussed earlier, the medical loss ratio that kind of reduces their price sensitivity. Even if they pay a higher price, it's all right. They can just, roll that back over into higher premiums. It's not as big a deal. Whereas for a consumer, if you pay a higher price, that means you have less money to pay on fun things. And so, yeah, I think introducing some more some direct consumer shopping into healthcare could be beneficial. I think we've been going in the opposite direction over the past 10 years, but I think there's a lot of opportunities for that. We instead of covering some of these services with no deductible, no copay, try to roll that back. And some people have talked about labs. I mean, I don't think lab tests are that expensive. They're unaffordable. But if you say that your insurance has to cover them, then you have no incentive to shop around and look at these different labs, these third-party lab providers, and go to them and get lower prices. Instead, you'll just go to the hospital because it's most convenient. And they have, I mean, it's not a monopoly exactly, but it's like a semi-monopoly on location. You're already there. What do you care? And that reduces the pressure to keep prices low. So trying to find little pieces like that to maybe push back onto the consumer so that there's some price sensitivity. There's another health savings accounts are another way to do this, where you have these high deductible plans, but you can also put your own money in these health savings accounts, and sometimes your employer contributes too. And so you have a pool of money where it can only be used for medical care, and it's not going to really impose on your other needs. And so you're incentivized to kind of shop around and look for providers that can offer you a good service at a value price.
Right. So, when we're looking at, reform options and, ways we can, tweak the system, reform the system for better outcomes, who do you think we should be following and listening to? So whether that's other policy analysts like yourselves or other organizations, people with like good innovative ideas, um, and then so kind of sources of kind of recommendations and analysis, but then also other kind of international players. Um, I read a book by Ruchir Sharma. He wrote a book called "What Went Wrong with Capitalism." It's not all about healthcare, but there's like a little part about there. He has a kind of a short list of some other countries that have some healthcare policies systems he likes. He likes Switzerland, as I remember. Presumably not Canada and the United Kingdom, I would guess. So who should we be looking to for answers? Are there people in groups or other countries?
Yeah, as far as other countries, I don't think any other country has it solved. I think there's a lot of benefit to be gained from looking at places like Germany, Switzerland, Singapore, the Netherlands. Germany and the Netherlands have and maybe Switzerland too. I think they have a mandate for health insurance. But after that, it's very competitive between these plans who are offering the insurance. Their citizen can choose what plan they want to use, so it has some competition between them. And I think there's a lot to gain. I'd say there's something to learn. I don't think we should emulate Canada or the United Kingdom, but looking at them to see why it's not working, I think is also valuable. Because I mean, I think the NHS, the National Health Service, is having lots of problems now. Um, it's politically problematic. They can't afford it. The costs just keep going up and up, and they can't get enough providers. They're having shortages of pharmaceuticals. There's just a lot of problems in the NHS, and those are things we should look at and for reasons not to emulate them. As far as other policy people, I think people at like the American Enterprise Institute and Heritage and Paragon and Cato, I think they're all worth looking at, keeping an eye on. We're all producing analysis, sometimes just to push back on some of the prevailing narratives. I mean, talking about Obamacare and some of the the unaffordability issues, the costs. You can get some deeper analysis and some more thoughtful how things are working from a lot of these groups. I think there's no shortage of people to follow, but to cast a wide net and to try to look for things you're not seeing elsewhere, and look for people who are digging a little deeper.
All right. Excellent. Well, Jeremy, thank you so much. This has been a great conversation, and I think it's given us, given everyone cause for concern, but also cause for hope looking forward. Uh, so before we go, tell everyone where they can find all of your valuable work online.
So all of it can be found at cei.org. All my blog posts and reports are all there.
All right. Thanks again, Jeremy.
Thank you.